All right, it is 12 o'clock officially. Hello, everybody. My name is Carissa Vandenberg Clark, and I will be talking about quality improvement and implementation today. My background is as an implementation scientist, so we usually we usually do much. Oh, I'm sorry. Okay. We usually take much more of a deep dive into quality improvement. So I'm just going to basically kind of show you the differences between sort of the more traditional strategy for quality improvement. And then if you are interested in kind of looking at some problems that are going on in your organization or why certain interventions aren't working, how you can do a QI study that focuses on that and actually kind of gets at the heart of the heart. So objectives are for us to start with the basics. We're gonna review the Plan, Do, Study, Act strategy. I'm gonna talk a little bit about implementation science and medicine. And then we will look at some of the models of implementation science. Basically these will help you kind of figure out which one is best for you to use given a certain situation you're dealing with. So starting off with the Plan, Do, Study, Act. Essentially, this is really easy, straightforward way of dealing with an environment in a very simple, with a very simple solution. So essentially, you start with plan. You plan the test or observation, including a plan for collecting data. Then you try it out on a small scale. Then you set aside some time to analyze the data and study the results. And then you refine the change based on what you've learned from the test. And then you can kind of do the whole thing over again. This is essentially very broad. What does planning necessarily look like? What does the do look like? What does the studying look like? What does the act look like? This is a lot of what implementation science focuses on. So this is Plan, Do, Study, Act was established as a way of testing a change that is being implemented. There are it's basically a four-step guide, and the thinking process breaks it down into steps where you evaluate an outcome, you improve on it, and then you test again. You probably are doing this anyway. I'm going to give you an example. Once I'm able to find my internet.
Believe it or not, every day you go through a PDSA cycle. For example, every day when you get in your car and start to go to work, you go through a PDSA cycle. You get in the car, you listen to the radio, you've planned your trip, you're heading down the road, and then you're told that in fact, there is a wreck on a road that you typically use. So you've planned your journey, you're doing it, you're studying it now because you're getting feedback off the radio, and then you discover that this road is closed. So what do? You take that information, you put it into your brain, and then you say, I'm going to get off this road and I'm going to take a different route to avoid that accident. You've just gone through a PDSA cycle. Similarly, let's say that you had a sick house plant, and this plant was not doing too well. You could try a number of things. You could try more water. You could try fertilizer. You could try a bigger pot because it's root bound. You could try a variety of things. But again, you would be doing Plan, Do, Study, Act. So as we think about the PDSA cycle, it is a very simple thing, yet many people can describe it, but they've had trouble carrying them out. Historically, the PDSA cycle was developed by a gentleman by the name of Walter Schuhart. Walter Schuhart, back in the 1920s, working at Western Electric in Cicero, Illinois, and in New Jersey, took the scientific method, that is inductive and deductive thinking, where you go from the specific to the general, from the general to the specific, with hypothesis testing. He took that scientific method and turned it into a very simple notion that when we're going to do something, we're going to plan it, do it, study, and act. Now remember, Schuhart and his students, Deming and Juran, were working on the shop floor at Western Electric. They could not, as PhDs trained in physics, engineering, statistics, take the academic scientific method and apply it to shop floor, where people were working, making old-fashioned telephones. Those people, many of which did not read, could not explain the scientific method, were very, very engaged because Schuhart was able to take the complexity of this and turn it into a very simple thing that we do every day. Plan, do, study, act.
All right, so hold on one second. Let me be smooth about this. So, as we see, I mean, it's pretty straightforward how this plan, do, study, act. You're doing it oftentimes already. The plan part is where you write a concise statement of what you plan to do, what you're going to test. I mean, this could be sort of essentially a research question. After you have your plan, you execute it, or you set it into motion. Somebody needs to turn their mute off. Doing this implementation, you will be keen to watch what happens once you do this. After you implement whatever you're doing, what did you learn? Did you meet your measurement goals? And here you'll record whether it worked or you didn't work. And then what did you conclude from this cycle? Here you'll write what you came away with for this implementation or for this project, whether it worked or not. And if it did not work, what you can do differently in your next cycle to address that. If it did work, are you ready to spread it across your entire practice? Can you repeat the same practice again and it works the same way? So here's another YouTube, if you bear with me. That says it a little better than the way I'm going to be able to say it.
Believe it or not, every day you start small with small tests of change.
All right, sorry about that. I guess it was actually a repeat of the same one. So however, to be clear, there's a big difference between making sure you're improving the quality in your health setting versus doing what we would consider a kind of a more in-depth implementation study of whether or not something works. So the first thing to recognize is when you have an intervention, you're not rolling it into what is typically a lab setting. So most of the things that you maybe read a paper and you see that somebody did some type of practice. A lot of times these practices aren't tried in clinical settings. They're tried in a lab setting where there's a lot of things controlled for. So whether or not it's going to come together, and when you try to do it in practice, it looks the same, is a whole other affair. This essentially is what we would consider to be, where we're able to get these interventions to work in practice, things that science has taught us, things that we get guidelines in which tell us, how we're supposed to practice. How we do this is oftentimes a black box. which makes it often unclear for us in terms of capacity and why something we are doing works or doesn't work. And, you know, this is why there is what we consider to be a translational science spectrum. The translational science spectrum represents each stage of research along a path from the biological basis of research and disease to interventions that improve the health of individuals and the public. The spectrum is not linear or unidirectional, and each stage builds upon the previous stage, and it informs all the other stages. At all stages in the spectrum, it develops new approaches, it demonstrates their usefulness, and it disseminates findings. Patient involvement is also a critical feature of all these stages in this type of science. So, I mean, you can see how the stages of science work. Basic science research basically involves the scientific exploration where you can reveal fundamental mechanisms of biology, diseases, behaviors. And, you know, even when you think about it, these stages of transitional, when you get back to the translation, this research also builds upon and informs basic research. So it goes back and forth. You know, the preclinical research, you know, that basically connects to the basic science of disease with human medicine. During the stage, scientists develop a model of intervention to further understand the basis of disease or disorders and to find ways to treat them. So this is basically where the testing is carried out using, you know, animals and animal models. You know, during preclinical research, we're not even using humans yet. It's not until clinical research that we start to use humans. And then we can understand how the disease works or the medication or whatever it is works in a human body. This goes really further into what we consider to be public health. And this is the stage of translation where researchers study health outcomes at a population level to determine the effects of diseases and efforts to prevent diagnose and treat diseases. So, you know, the findings that kind of when we get to the community translation, this is what a lot of public health does. It helps guide scientists working to assess the effects of current interventions and develop new ones. You know, essentially, you know, this is sort of how a lot of us see you know, even developing interventions within our own medical and health practices. So if you're interested in being, you know, not just a practitioner, but also being somebody who innovates new programs and practices, there is a lot of different steps in which that occurs. So, you know, we can refer to this as sort of a process of discovery. So people get many different ideas. You know, you will, as you go into your clinical practice on how to do things better. But it doesn't necessarily mean that, you know, you may have these great ideas, but it doesn't necessarily mean that those ideas will be taken and run with right away. We call this the leaky funnel. So what they usually find is when they find really promising interventions and they find really promising you know, strategies, when they find medications that are really promising, there can be 17-year odyssey before these findings find their way into practice. Part of this is you have to get money for it. You have to get the research funding. Then you go through what is called the peer review process, which takes a long time. There's the peer review process with the grants. So you're applying for grants over long periods of time. That can take years and years and years to get the money for it. Then there's the publications to get the peer review. Those publications have to be important enough that people read them. Then there's, it goes further on through different types of research syntheses. You have to get some systematic reviews to kind of hook it up. And then finally it makes its way into a guideline for evidence-based practice. And then it can kind of be pushed into practice. So you can see this is a really long, arduous path. And it can take a long time for new, interesting things to happen in our practice. So think about this when we think about something like penicillin. So, we make this assumption looking back at time that, some really, great man came up with penicillin, and everybody was just waiting for him to come up with it. And then as soon as it showed up in the newspaper, then everybody just used it. But this was a long process. Fleming in 1928 discovered penicillin, but it took 15 years for Florey, somebody else, a Rhodes Scholar at Oxford, to evaluate whether penicillin worked in humans. Then it wasn't even tried with the civilian population. It started being used among people in the military first, and then went to civilians in Austria, not the US. So there had to be systems for large-scale production, and disseminations weren't even in place. So this all had to be in place before people were able to get it. So we could think about how much issues would have been resolved if penicillin would have been, would have come right when it showed up, right? Dissemination and implementation research. The Institute of Medicine defines implementation research as an important component of the framework for clinical research. And this component is important for re-engineering clinical research experience. It's also important for re-engineering health systems and prevention systems. We have what is considered a roadmap for how this occurs. They have, when you work with the Institute of Medicine, when you apply for a lot of grants for research, you're doing this for different tracks. So there's a T1 for basic science, there's a T2 for clinical research, and there's a T3 for what is considered dissemination and implementation research. And this is where guidelines are developed for practice. This is where practice is moved into health, where research is moved into health practice via diffusion, dissemination, and delivery research. So what does this look like? So there's a whole bunch of different models of implementation. One of the more well-known models has been established by Enola Proctor, who's actually used to be one of my professors at Washington University. She created a model that focuses on how evidence-based practices are measured, and if they are, how we can consider them to be effectively implemented. So again, when you're looking at implementation outcomes, you're looking at different outcomes than what we would consider to be efficacy. So there's an efficacy measure that is separate from some of these other outcomes that they look at. So a lot of the outcomes that what we're looking at is we evaluate the effect of strategies we're using to make this intervention happen, the resources we're putting into it, and then we think about different types of outcomes. Like if this is a feasible intervention to use in our specific organization. if we're using the we're using it with proper fidelity, that basically means, is this intervention being done as it's designed to be done? Penetration is where we're basically seeing how, it's sort of a reach question. How much of our organization is actually using this intervention? How many primary care doctors are providing a depression screen, for example, when people come in? And what are all the complexities for doing that? Is it feasible to provide a depression screen when people come into this office? What is going on organizational to keep the depression screen from happening? When they get the depression screen, are they doing it with the correct fidelity? Are they asking all the questions in the right order? Does everybody get all the questions? Do they only ask the first two questions and for everybody, or alternatively, they don't use the skip patterns they need to use in that specific type of screener as it's indicated to use it. Sustainability and acceptability and uptake and costs are other ones. Acceptability is like, do patients really hate it when you ask this of them? Do doctors really hate to use this measure? Sustainability is how long, if we don't have to use this measure, if we're not going to be paid to use this measure, if there's nothing in place to use this measure, what's going to keep us using it in the long term? And the costs are another thing that people look at. So these are all important questions. So when you do a plan, do, study, act, when we think about why something isn't working, a lot of what Anola Proctor, outcomes that she came up with can be very useful in better tailoring your problems and your questions. This is just a little bit more, and I'm guessing you'll get a copy of this afterwards. And this basically defines all the different ones in here. I think there was one. Yeah, they're all in there. So, I mean, we know in healthcare that there's really quite a lot of problems that are very complicated to understand how they work. I mean, a perfect example is the complexity that people sometimes have even just making an appointment. So if we're looking at some sort of broader problem within our health centers, like, well, people aren't showing up for appointments, or people are not following up on care they need to have, an implementation study can be very effective in targeting in how that works. And so sometimes you can't just do a plan, do, study, act. You have to get at more fine-grained answers. So there are other models out there that are oftentimes used in health settings that I'm going to talk a little bit more about, that I really encourage you, if you, especially if you get into more health administrative work, or if you're a medical director at some point, to really be aware of. The first one is a Quality Enhancement Research Initiative, which we refer to as a QUERY. This came from the Veterans Health Administration. It's really interesting because obviously they have pretty large health systems. So they are going to, really go out of their way to come up with an effective approach to do quality improvement. There's also the kind of a well-known earlier model called the REACH Effectiveness Adoption, Implementation, and Maintenance model. This is not as simple as, it's kind of a middle ground between kind of more complex models and then the really simple plan, do, study, act model. Then finally, a kind of a more recent model, which is that sort of tries to like cover everything. And it's a very, I mean, it's a model that, if you have a really large, complicated issue, you want to, and you have resources to have investigators look into and analysts look into is the consolidated framework for implementation research. So we're going to start with the query. This is basically started in 1998 as a key component of the Veteran Health Administration. So this is basically, you know, the larger kind of veteran hospital organizations effort to sustain and examine and improve quality of care. It basically combines, you know, the evaluation of clinical care delivery, health services research, and policies actions intended to identify best practices. I mean, this is partially because the VA is a government agency, so a lot of times they're responding to specific policies. And so they're doing a lot of what we would consider to be policy implementation research too. So the processes include identifying high-risk, high-volume diseases or problems, then looking around to find out what the best practices are for those problems, defining existing practice patterns and outcomes across the VA and current variation from best practices, then identifying and implementing interventions to promote the best practice, and then documenting that best practices are improving your outcomes, and then documenting that the outcomes are associated with improved health related to the quality of life. So in other words, and you know, essentially what they're doing is they're looking for a model or a practice that's being used, that's being successful somewhere else. And then they basically bring it to their specific location or their setting, and then they may change it a little bit to fit to their setting, and then they basically test it to see how well it's working. So they do this in a series of steps. They start with a really small site pilot. Then they do what would be considered a multi-site implementation trial. And then they do a larger scale multi-region implementation trial. And then they roll it out throughout their system. So, I mean, we think about health systems, this is sort of a really interesting and important strategy for how you do it. I mean, right, in St. Louis, we have the SSM health system. They have locations, I think, in 3 different states. So, I mean, if they start at, we'll say like St. Louis SLU Care, we would have a single site pilot showing up on our SLU Care site as a pilot. And then we would try a few multi-sites, right? And then then we would try maybe all of St. Louis, or we would try all of Missouri. And then when we see how well that works, then we go across the entire system. And you know, the VA has been doing this for a while. They have a number of different centers. They're very interesting to look up what those centers are doing and the research they're doing in them and the interventions they're doing. They're all online, so I recommend, if you have an interest in any of these areas, to look at how the VA query centers around this. The consolidated framework for implementation research. Again, this is the complicated one. And essentially, this is where you do probably, you know, a combination of survey research and qualitative research that gets at inner and outer settings, intervention characteristics, processes that are occurring within them, and characteristics of the people that are getting the services. We see that we have really pretty large boxes around the inner setting. And this is largely because we're really trying to figure out organizational issues that are going on that are making it difficult to do a specific intervention. So, you know, I know in medical settings, we oftentimes, you know, you often will have the intervention being a medication. And, you know, sometimes it can be pretty straightforward, but even that can have its own complexity in terms of getting, you know, the usage of a specific medication, especially if it's not necessarily, if there's certain payers that will pay it and certain payers that won't. There's different there's different perspectives organizationally around the medication. There's any kind of side effects related to the medication. This could, and then which is probably also related to the culture and the climate within your own health setting around this, and how much discretion you have as a provider within your own setting. So all of these things, even something like a medication, can be something that there can be a lot of complexity around. Here's another way of looking at this. I mean, it really kind of shows you this is sort of one of those meta theories where you have a number of different theories that are actually kind of tying in with each other to explain something. And you're getting at all these different domains where interventions are taking place. So then there's also what we would consider, there's another kind of way of looking at research that implementation research that's a little bit more, I wouldn't say, I mean, to some degree it's cutting edge, but sometimes it's also dealing with some of the world issues that we have, like greed and power, that aren't always considered as clearly within these kind of more generalistic models. So, I think I a lot of times have used the example of mental institutions. So in the real world, you're dealing with systems of power and privilege. You know, in mental institutions, we have seen significant changes. And a lot of those changes had to do with early studies in the 60s and 70s related to how mental institutions were implementing different interventions, what was going on within mental institutions, how did they do their work. So, I mean, just giving you an example, if we started with a case example of a practitioner in the 50s, it was not uncommon for them to have, to have patients with depression or moderate to severe depression. And at that time, EST was a intervention that was indicated for it. And I mean, sort of the issue with some of the studies that were coming out around EST was laid out through some of the ethnographies that came out, had criticized many of these existing studies, which oftentimes they would include, administrative records showing that people were released afterwards or their behavior was better. And of course, the reports were coming from the doctors. And sometimes they may be coming from the patients, but it doesn't get into the reasons and how their behavior improved. So I'm just going to read this section from one of the ethnographies because I think it's an interesting way of thinking about that. So attendants put those patients in electroshock therapy when it feels that they may be acting up or causing trouble or have become disturbed or show a strong evidence of becoming disturbed or violent. In addition to these patients, there are 3 or 4 patients who are on a list more or less routinely for what is called in the ward maintenance therapy. There are patients who had a continuous history of violence or disturbance on a ward since admission until they're put on a shock series, which may last for as long as 3 months. The amnesia and disorientation produced in these patients by the shock treatment keeps them quiet and prevents their disturbing or hurting the other patients and upsetting the ward routine. On all the lists for shock made by Mr. Albright and Mr. King, there was always several patients who were on the list for insubordination to the attendants or to a ward helper or for having fought each other. Among patients in attendance, there is a widely circulated knowledge of administration of the treatment and its effect on the patient. The knowledge is based on the fact that some patients in Ward 30 have assisted in the shock team in the administration of therapy to patients, holding them down, helping to strap them in the bed, or watching them after they have quieted. The administration of shock on the ward is often carried out in full sight of a group of interested onlookers. The patient's convulsions often resemble those of an accident victim in agony and are accompanied by choking gas and at times by a foaming overflow of saliva in the mouth. The patient slowly recovers without memory of the occurrence, but he or she has served the others as a frightful spectacle of what may be done to them. Moreover, in the early disorientation and vacuity of the state of recovery, he is obviously upsetting to other patients. Patients who have not seen shock therapy are provided with a detailed description by those who have. So, I mean, what do you think, why do you think, thinking about this example of how this intervention is used in a mental institution? In other words, it's used as a method of control. How would people respond to this? The institution likes it because it helps control patients in one way or another that they would be considering difficult patients. So they want to keep this intervention in their tool belt because it makes their job easier. The patients are in a coercive environment. So are they, they want to say that something helped them so that they don't get it again. So this, where we think about a lot of this stuff and, why something is working or not working is sometimes we're living in a situation where people are making assumptions about something working because it is done by something with a very high level of legitimacy. And this is what these types of studies did. They questioned these assumptions. And they did this using a lot of times qualitative methodology because you're able to kind of be on the ground. You're able to kind of see how things kind of unfold over time. A famous one that's been done, and if you're really interested in mental health and mental institutions and like I was, and I have been, is Goffman's Asylums, which basically looked at people in institutions and sought to interpret their experience. So these studies led to a greater focus in organizational sociology, which focuses on systems of power and privilege. They've also led to, kind of different ways of structuring how organizations work. So one of my mentors in graduate school basically came up with the concept of people processing organizations. This is what, human service organizations, that means health providers, it means social service providers, it means any kind of organization that services human well-being does. They will basically measure attributes of a person in a situation, a patient, or, if we're thinking about health settings, they measure patient attributes and situation, they assess it to see if they are subject to any kind of official action. Choices are made among some alternatives. And at the same time, they're making these choices in relation to their existing relationship with other organizations, the market, government. Providers have a lot of discretion on how and what services are provided. And the patients oftentimes have little knowledge about the potential alternative markets. This also brings, I think I'm going to bring this one up first because it's a little easier. This also brings, up the political economic model. This is a very important model that came out, you know, I don't actually know the date it came out. I think it was actually very early, in the 1900s, but it highlights the centrality of power relations to the, basically, and when we think about these power relations, it's really important to figure out how this affects patients. So a political economic perspective would basically provide a framework for analyzing how changes are implemented in a human service organizations, or what, if we have an equity plan, what does that look like? How in a political economic framework does an equity program actually get implemented in the end? Let me see what else we should talk about here. Its success or failure is determined by the ability of the change agent to basically bring about a favorable shift in the allocation of resources. So a lot of these models are studying, if there's actually, if we can kind of more distribute or reallocate resources more equally. It's an interesting model to use. There's a heavy focus on how an organization works with the surrounding environment. So that means with other organizations, we can think about, how it works with government, how it works with businesses, how it works in media, how it works with, with schools. There's also technological factors, and with technological factors, this also means like specific, things that people are trained on. So nursing technologies or procedures or protocols. But there's also these internal power and inducement patterns. With political economy model, I think right now we also think in terms to a large degree that of institutional theory. A lot of times tie hand in hand, and this is to a large degree is because there are certain institutions that have more leverage and power than other institutions. So just stepping back a little bit, the institutions, according to this theory, are sort of these supra-organizational patterns of human activity by which individuals and organizations produce and reproduce their material substance and organize time and space. So institutions are basically like something like medicine. That's an institution. The military are an institution. Business is like an institution. Social service, human service is like an institution. Police is, and criminal justice is its own institution. And so all of these different institutions are working with and against each other. And we can oftentimes think that also when we have interprofessional teams, we're also working across a lot of times different institutions, like medicine against sort of this behavioral health, social service institution, or allied health institutions that have different symbolic systems. They have different ways of ordering reality. And this renders, a different experience of time and space and what is meaningful and what's important. And this is why it oftentimes is very difficult to really, figure out how to create very effective interprofessional teams. Important to step back and recognize that a lot of these logics are socially constructed. There's basically, patterns of material practices, assumptions, values, beliefs, rules, which organize the time and place. They provide meaning to this social reality. And, the key decision makers, and who is the people who are the key decision makers? They oftentimes are following a specific logic. So whoever is the person that is in charge, the logic will a lot of times go in the direction they want, and the logic will determine what those issues and solutions are. Sometimes that works, sometimes it's not. So when we think about it, in the case of healthcare and hospitals, a lot of times a business logic is used within medicine. Sometimes sometimes those two, business, work really well together, but sometimes they don't have consistent perspectives and they're working against each other. And so what ends up happening is you get back to the political economic model. Which one has more power? And that's the direction it'll go. But sometimes it's not a good outcome if, depending on the situation, if business or medicine is in charge of that. And so that can also be a question to ask. So going back to one more is Lipsky's street level bureaucrat. I like this one because it really feels like kind of the day-to-day life of a lot of healthcare fields, especially primary care. But my background is in social work. Social workers have this real kind of street level bureaucrat. It's a frontline worker focus. And kind of with the recognition of when you're sort of at the front, you're working directly with the public, you essentially are acting as a liaison between what is essentially government and business policy, and the public. Through this role, you have a certain amount of discretion, but sometimes, and it really varies on the situation. But you still have to work within the rules of the law, the institutions, the organizational power, policy, and whatever power structures are in place. There's also whatever technologies you have in place. So the electronic health record, this will affect a lot of people's discretion. There's also what oftentimes happens is people's working conditions affect their discretion and the decisions that they're making. And through these decisions, you can a lot of times see how things are unraveling and how implementation outcomes occur. So this brings us to the re-aim, which is kind of this middle ground simple model. The goal is to address these kind of key issues in program policy delivery and results that if you put them all together, they increase the probability that it can be successfully implemented and sustained. This is intended to help people who develop interventions, programs, and other types of research. It addresses the issue at both an individual and a setting staff level, and the consistency and lack of results are important at each level, especially the subgroups and focus on health disparities. Cost is also highlighted because it is always a key consideration for implementation. I mean, if something is too expensive, it's really difficult to get it to work. So essentially you have this reach, which is, asks some of these questions like, can the program attract a large represented percentage of the target population? Or can they actually get access to it? Can the program reach those most in need and most often left out? Poor, low literacy, numeracy, complex patients. Is it effective? Does the program produce robust effects across subpopulations? Does the program produce minimal negative side effects and increase the quality of life or broader outcomes? Adoption. Is the program feasible for the majority of the in a real world setting? Can it be adopted by a low resource setting and typical staff serving a high risk population? The re-aim has the flexibility a lot of times to take on some of these complexities. Implementation. Can the program be consistently implemented across program elements, different staff, time, resources, etc.? Are the costs, personal, upfront, marginal, scale up, equipment, etc., match how, the effectiveness? I mean, does it create any kind of cost savings for the money that has to be spent? Can the setting sustain the program over time? You know, without added resources and without somebody having to advocate for it or provide leadership for it. You know, the aim, so there's the re-aim guidelines, but there's this phase 2, which also hits a lot of times these kind of core power elements. The expansion and focus on community and non-individual focused applicants. Why policies are more effective than programs because of their reach. Summary metrics to measure overall impact. Impact score by an individual so that you can create these kind of composite scores. But there's also an efficacy score, which is like the cost divided by the individual impact, and the setting level impact score, which is basically this composite adoption score. So I'm gonna stop there and ask if anyone has any questions. I'm right at 12:50, so it gives everybody some time.